Our next speaker is Dr. Matthew Taylor. Dr. Taylor is a board certified in medical oncology and internal medicine. As a physician scientist, he divides his time between his clinical practice in the Franz Clinic at the Robert W. Franz Cancer Center and his research lab in the Earl A. Childs Research Institute, a division of the Providence Cancer Institute. His clinical specialties include treating patients with melanoma and advanced thyroid cancer and conducting early phase clinical trials. Dr. Taylor is fabulous to work with. One of my favorite quotes from Dr. Taylor is, "Yeah, let's try this." So Dr. Taylor, let's try this.
Thank you, Chris, for the kind and generous introduction. Thank you to AIM at Melanoma Foundation for hosting this this fantastic symposium, and thank you to everyone who's with us today. So let's see if I can share my slides. So again, I'm Matthew Taylor, and I'll be sharing a few slides and thoughts about some new developments in the treatment of melanoma. So I'll just preface my comments by saying that that this will in no way be a comprehensive review of all the new therapies that are currently in development. I'm just going to try to give a snapshot of a few things that we think are relevant and maybe worth highlighting. And some of the things I'm going to talk about are not necessarily new treatments, but new applications, kind of dovetailing with Dr. Curdy's final comments about the way we use some of these newer therapies in different phases of treating patients with melanoma at different stages of the disease process. Let's see. There we are. So I just want to start with this slide. This is from the same publication that Dr. Curdy referenced at the end. Dr. Curdy published this in the New England Journal of Medicine last year. And what I want to highlight is just the remarkable progress that has been made in treating patients with advanced melanoma over the past, let's say, 10 to 15 years. It's truly remarkable. Dacarbazine, a chemotherapy drug, was approved by the FDA back in the 1970s. And then it was a couple decades later before interleukin-2 was approved in the 90s. And as you can see from this slide, the 2-year survival for patients with advanced metastatic melanoma was still very poor. In treatment with dacarbazine, only 10% of these patients would survive to a 2-year mark. Interleukin-2, in those that were able to receive this therapy at the highly specialized centers that offer interleukin-2 therapy, the 2-year survival rate was about 23, 24%. And then, as you can see, there's been just an explosion of new drugs developed for treating advanced melanoma that have completely revolutionized the way we think about not just melanoma, but all cancers. And you can see that these therapies have dramatically improved the survival of our patients battling advanced stage 4 metastatic melanoma. So really remarkable to see not just the magnitude of improvement in survival of patients with advanced melanoma, but the acceleration of research and progress in developing new therapies. So really, it's been an incredible 12 years to see how much has changed and how this has impacted the lives of the patients that we love and treat. So with the advancement of immunotherapies, like Dr. Curdy mentioned, these are not chemotherapy drugs. These are medicines that boost and stimulate the immune system to recognize and fight melanoma. As we had seen from the large clinical trials we did in patients with advanced melanoma, the next questions became, well, what if we offered these same medicines to patients with earlier stages of melanoma? Can we prevent the melanoma from returning and spreading? So this is one of the clinical trials that was done with pembrolizumab, one of the PD-1 inhibitors or immune checkpoint inhibitors. And this is what we call adjuvant therapy. So adjuvant therapy refers to some form of treatment that is given after surgery to remove the melanoma and any lymph node metastases. And so in this clinical trial, the question was for patients with stage 3 melanoma, meaning that their melanoma had spread from where it started in the skin to one of the regional lymph nodes. If after surgery to remove all those tumors, if those patients were treated with pembrolizumab versus a placebo, would there be a survival benefit or reducing the risk of the melanoma returning? And what was very exciting in this clinical trial was that, sure enough, patients treated with pembrolizumab had a better outcome. They had a lower risk of the cancer returning over this 2-year period of time, as demonstrated in this clinical trial. So this was one of the really critical moments to learn that this therapy helps prevent melanoma from returning. It increases the chance of patients being cured after they've undergone surgery to remove all their melanoma. So this was a great milestone in treating melanoma. This has also been demonstrated with the kinase inhibitors. These are pills that target the BRAF mutation or the MEK protein. And these are gene mutations, alterations that drive melanoma to grow and advance. And similarly, these drugs have been tested in the advanced stage 4 metastatic setting and were shown to be very effective in shrinking these tumors. And so the question was, what if we offered these pills to patients who have undergone surgery to remove all of their melanoma? Can this also prevent a recurrence of the melanoma? And similar to the trials done with immunotherapy, this clinical trial also showed that taking these medicines, dabrafenib and trametinib, or Taflinar and Mekinist, these can also improve the relapse-free survival, basically increasing the percentage of patients who are cured after surgery and preventing the recurrence months and even years later. So this was also an excellent advance to see that we have multiple tools that we can use to try to prevent melanoma from returning when someone has been diagnosed with a stage 3 melanoma. Of course, this therapy is only available to patients who their melanoma has a BRAF mutation. So with the success of using immune checkpoint inhibitors in treating advanced stage 4 metastatic melanoma, and then the success seen in treating patients with stage 3 melanoma who had undergone surgery, the next logical question was, what if we offered the same therapy to patients with stage 2 melanoma? Would this also offer any benefit to those patients with a much earlier stage of melanoma? So this was a clinical trial that used pembrolizumab or Keytruda for treating patients who had been diagnosed with stage 2B or 2C melanoma. So again, in similar fashion, these patients underwent surgery to remove their tumor in its entirety, and then they were enrolled in this clinical trial, and it was blinded and randomized. So the patients nor the doctors knew what treatment they were receiving, and they were receiving either pembrolizumab, the immunotherapy drug, or a placebo infusion. And at the conclusion of the clinical trial, what we found was that patients who had been treated with pembrolizumab had an improved outcome. They had less of a risk of recurrence of the melanoma, a greater chance of being cured after their surgery and their treatment. So this again was exciting, and this has now been approved by the FDA for treatment of patients who have been diagnosed with stage 2B or 2C melanoma and have undergone surgery to remove those tumors. So Dr. Kurdi alluded to this, and so this is the concept of neoadjuvant therapy compared with adjuvant therapy. And what this means is neoadjuvant refers to giving some form of therapy prior to surgery to remove all the tumors. And so this clinical trial, known as the SWOG or S1801 clinical trial, was designed to ask the question, is it better to give immunotherapy with pembrolizumab prior to surgery or to give it after surgery for patients who have stage 3 or even stage 4 melanoma that could be surgically removed? So these patients were put into 2 different groups or cohorts. And so again, this was patients with stage 3B or higher melanoma that could surgically be removed in its entirety. So the neoadjuvant group, these patients received 3 cycles or 3 doses of pembrolizumab before they underwent surgery to remove all their melanoma. And then after surgery, they were treated with 15 additional cycles or doses of pembrolizumab, which is given once every 3 weeks through an IV infusion. The other group of patients were assigned adjuvant therapy, which meant that those patients immediately underwent surgery to remove all of their melanoma, and then they were treated with 18 months of pembrolizumab, which is currently one of the standard approaches for treating a stage 3B or a surgically removable stage 4 melanoma. Throughout this clinical trial, they enrolled 313 patients, and they found that survival was better in the patients who were treated with neoadjuvant pembrolizumab compared with those who only received the adjuvant therapy. So essentially those that got 3 treatments with pembrolizumab before they underwent surgical removal and then had 15 doses of pembrolizumab, those patients did better, lived longer, had less of a chance of recurrence than those who underwent surgery and then immediately were treated with the adjuvant immunotherapy. Side effects were similar in both groups. So this is a really exciting clinical trial. And by the way, this is very new. This was just presented at the large cancer conference, the ESMO meeting. This was presented, I think, just a few weeks ago. So this is very new data, and as of yet, none of these medicines have been approved by the FDA for use prior to surgery. But we're very intrigued by these results, and we anticipate that it's very likely that as more research matures and data becomes available, that this may become something that becomes a standard for our patients in the future. So more to come, but very exciting to see that this might offer some benefit for a selected patient population. This is another neoadjuvant clinical trial for patients with melanoma. This is called the Prado clinical trial. This is an interesting design. And so this is for patients who, again, have stage 3B or 3C melanoma. And specifically, this has to be patients who have lymph node metastases that can either be felt by physical exam or they can be seen on CT scans, that we know that they have tumors in the lymph nodes. So patients in this clinical trial that qualified having lymph nodes that were enlarged from melanoma that they can see on a CT scan, these patients were treated with 2 doses of ipilimumab and nivolumab. After the 2 doses of immunotherapy, they underwent surgery to remove that dominant lymph node that was seen on the CT scans. And then the pathologist would assess this to find out how effective those 2 cycles of immunotherapy had been. So in the green box, if those patients had a major pathologic response, meaning that there's less than 10% of melanoma that's still viable in that lymph node metastasis, those patients did not undergo further surgery to remove any tumor, and they did not receive any further immunotherapy. They were just now in observation doing CT scans or ultrasounds to monitor for signs of recurrence. In the yellow or the orange square, if patients had a partial pathologic response, meaning that there was between 10 and 50% of the cancer cells that were still viable, those patients would go on to receive a therapeutic lymph node dissection. Surgeons would go back in and take out all the lymph nodes from that region. And then those patients would be monitored with scans, but no additional immunotherapy. And then in the pink, if patients did not have any response, if there was a pathologic non-response, meaning there was not significant evidence of the immune system attacking and destroying melanoma within the lymph nodes, those patients also would go on to have complete lymph node dissection to remove the melanoma from the lymph nodes. And then they would go on to receive adjuvant therapy with either immunotherapy or targeted therapy. And what they found, which was an interesting observation, is that the patients who had a really profound response in the green, meaning that a substantial amount of their tumor had shrunk and been destroyed by the immunotherapy, these patients had excellent outcomes with excellent long-term survival. Whereas the patients who did not have an excellent response from the immunotherapy, their outcomes were not as good. So this information is very interesting in that it might provide some evidence to suggest where we can eliminate therapies that may be unnecessary. So for example, for the patients who had an excellent response to just the 2 doses of immunotherapy, this trial is suggesting that those patients may have no need to undergo an extensive surgical removal of their lymph nodes, and they may have no need to undergo an additional year of immunotherapy. So if this can help to stratify which patients need additional therapy and which patients can be spared additional surgery and therapy, this would be a tremendous advance for the field. So we're encouraged by this and excited to see how additional data turns out and how this might shape the way we think about treating melanoma in its earlier stages in the future. This is just to show there's another neoadjuvant clinical trial with a different design. So a number of clinical trials are asking these questions. Is it better to give these therapies before surgery or after surgery? So hopefully the coming years will provide more guidance on how to use these therapies effectively. I want to shift gears now and talk about some other therapies. And so this is not a new therapy that I'm going to talk about. This is an old therapy that's becoming new again. So this is something called adoptive cellular therapy or adoptive cell transfer with what are called tumor infiltrating lymphocytes or TIL. So the way this works, and this was pioneered back in the 1980s by Dr. Rosenberg. And so what this process looks like is that they surgically remove a tumor from one of the metastases from a patient with advanced melanoma. The tumor is then chopped into small fragments and is cultured in a dish, in an incubator, in a laboratory with different cytokines like interleukin-2 to stimulate the proliferation and growth of the lymphocytes. These are the immune cells that have found their way into the tumor and are trying to fight and attack the cancer. And so these lymphocytes from the tumor are grown and expanded in a laboratory. They're then selected for which of these are responding to proteins that are on the melanoma to basically enrich for the lymphocytes or the T cells that are most likely to attack the melanoma. And these can be expanded to huge numbers into the billions of T cells. And then all of these T cells are then reinfused back into the patient. So the concept is, can we isolate the T cells, the immune cells that recognize melanoma, expand them into a massive clonal army of immune cells, and then give them back to the patient with the hope that these will go find and attack the melanoma. So a clinical trial was done recently by a company called Iovance, and they are hoping to commercialize this adoptive cell therapy TIL product for patients with advanced melanoma to basically make this more accessible. Because as you can see from the previous slide, this is a very complicated procedure that requires a lot of expertise, both from the surgeons and the laboratory and the doctors infusing the cells to manage this. And this is something that has not been widely accessible for patients with advanced melanoma over the past several decades. So in this clinical trial, patients, just like I explained before, would undergo surgery. They would isolate the lymphocytes from their tumor metastases, expand them up, and then reinfuse them. And this was specifically for patients who had already been treated with immune checkpoint inhibitors, and their cancer had either not responded or had ceased to respond to those therapies. So in this clinical trial, patients were first treated with some chemotherapy in an attempt to try to reduce the lymphocytes that might prevent the immune system from fighting the cancer. They then receive billions of their lymphocytes to attack the cancer, and they would then receive up to 6 doses of high-dose interleukin-2. And in this clinical trial, they found that this therapy was very effective for shrinking the tumors for about 36% of patients. The 36% of patients had a dramatic response with the tumors shrinking. And some of these patients were able to survive many months and sometimes years. So this was an encouraging observation that validated some of the efficacy that had been seen in previous years from this type of adoptive cell therapy. So this has not yet been approved by the FDA. The FDA is still reviewing the data, and I'm hopeful that at some point in the future, this will be a therapy that is more accessible to more of our patients around the country and the world. So I want to shift gears now to a couple of clinical trials that we're working on with newer types of therapies to attack melanoma. So this is a cytokine. So this is a protein that is involved in regulating how the immune system responds to cancer and a way to try to activate the immune system to fight cancer. So interleukin-18 stimulates the immune system to recognize and fight cancer. There were some clinical trials done years ago where they treated patients with interleukin-18, but unfortunately the trials all failed. There was no sign of significant anti-tumor efficacy. So that was frustrating for the field. And the question became, why did that happen? So some additional research showed that many tumors produce high levels of a protein called interleukin-18 binding protein. This is essentially a decoy receptor or protein that binds and neutralizes interleukin-18 and prevents it from stimulating the immune system. So the previous trials had failed because while they would infuse patients with interleukin-18, as soon as that protein drug would get into the tumor would neutralize it with this protein. So this pharmaceutical company that we're working with called Simca Therapeutics, they developed a variant, a modification of interleukin-18 that is resistant to being neutralized by this decoy receptor protein. So the concept is that their modified interleukin-18 would now be able to stimulate the immune system to attack the cancer and not get destroyed or neutralized by this protein. So we are conducting a phase 1 clinical trial testing this in patients with a variety of cancers. And we've already seen some encouraging signs that this might be able to activate the immune system to fight melanoma. So this is very encouraging. We're excited to be a part of this clinical trial and hope to see that this offers a new therapy for patients with a variety of advanced cancers. This is another clinical trial that we're conducting in collaboration with a company called Immunotherapies. And so this is targeting a unique protein called LILRB2. So this is a protein that is found on the surface of a different branch of the immune system called the myeloid cells. And these cells have an interesting function. Many times within a tumor, these cells have what's considered a tolerogenic role, which basically means these immune cells, these myeloid cells within the tumor, are almost protecting the tumor from the immune system. Almost, they're defeating the goal of the immune system to fight and attack the cancer, and they protect the tumor and facilitate the growth and spread of the cancer. So the goal of this drug, IO108, is to block this protein to kind of reverse this function of these myeloid cells to get them to stop protecting the tumor and cause them to start to generate an environment within the cancer that would facilitate the immune system to attack and fight and destroy the cancer. So we are conducting this phase 1 clinical trial right now in patients with a variety of different cancers. And we've been very gratified to see that this is showing some early signs of success in patients with a variety of different cancers. So there's still a lot of work to be done with this, but we're very encouraged to see these new drugs coming through clinical trials and showing some efficacy in being able to stimulate the immune system to fight and attack cancers. So now I want to shift gears and talk not about immunotherapy, but more about targeted therapies. So we mentioned earlier on, we use BRAF and MEK inhibitors to target melanoma that has a BRAF mutation. These drugs work very quickly. They can shrink tumors that are very large and help patients feel better very quickly. The problem with those drugs is that unfortunately, the cancer oftentimes develops resistance to these therapies over the course of sometimes a year or a year and a half. And so we are in desperate need of better drugs that can overcome the resistance mechanisms to these drugs. So The other problem we have with our current BRAF and MEK inhibitors is that they don't get into the brain very effectively. And so when patients with melanoma have tumors that have spread into their brain, these therapies are not very effective. So some new drugs that are in development overcome these resistance mechanisms to the conventional BRAF MEK inhibitors, and they also penetrate the brain very well. So we are just about to open a clinical trial with a pharmaceutical company that's developed a drug to do just these things. And we anticipate this trial to open in the next probably 6 weeks. And we're hopeful to find out if this is effective in treating metastases that have gone into the brain and tumors that have become resistant to the BRAF MEK inhibitors that we use currently in the clinic. So I'll just summarize now. The past 10 years have been remarkable. It's been incredible to see how many new improvements have been made in treating patients with advanced melanoma. There are several new immunotherapies that are advancing the field that we hope will provide benefit for patients who have not responded to the currently available immunotherapies. And there are new drugs that are being developed that will target gene mutations within melanoma that we hope to offer additional therapeutic options for these patients. But we still have a lot of work to do. So we're extremely excited by the progress that has been made, but there's a lot that still needs to be done. So with that, I'll just wrap up and thank you all for being here today, and thank you for your attention. And I'll give a special thanks to our courageous patients who have participated in clinical trials and have helped us to get to where we are with the current state of therapies for melanoma. Thank you.
Thank you, Dr. Taylor. So exciting, some of the results that we're hearing, especially the Prado study, answering some really interesting questions to help reduce toxicity in our patients, whether that's surgery or further immunotherapy. So thank you for sharing that.